Hey James, how are you doing tonight?
Where is that BMW bike now that you have your second generation Ducati?
I still have it. I rode it to the office tonight
Really?
for the
Yeah,
dental show live. I'm not getting rid of that little guy. It's too much fun.
that's a classic. I love it. So you were out on your Ducati this morning, weren't you?
I was out zooming around, yes, and just we have great weather in Texas right now. It got up to like
Yeah,
64 and sunny, and just you got to get outside, especially while we still
yeah.
can.
That's the truth. Yeah, they're doing a few shutdowns in some counties south of me here. So, but I heard that
Yeah.
dentistry is still essential, which is good. We're
Yes,
going to
we
be
are
talking about some of the
essential.
essential stuff tonight.
Yes, we are. We're going to talk about PrimeScan for sure. And but
Yeah.
I was thinking as I was out on my zooming ride out on my Ducati today, I was thinking, you know what? I'm going to ask Clem a question tonight because it just kind of crossed my brain. Yeah,
Yeah.
how do you? Now, I joke with my patients a lot, and so I don't know if that's a good thing or not. I've run into situations where maybe the relationships have become a little bit too personal. I don't know, but kind of lose a little bit of the professionalism possibly. How do you react, or how does your team react when they call you by your first name?
I
Or
think
does
that's
that?
totally individualized. I have a lot of clients that call me by James,
Yeah. And
and I think within our team we still go through the Dr. Clem. That I think be yourself. I don't. We build our practice based on who we are as people. Um, I would say some people that have been clients of mine for years. It's more than just a client; it's a friendship, and yet I'm careful about those that try to make it a friendship too soon, if you know what I mean.
sure.
And then they
What
can
if
come back.
that patient is 22 and they call you James?
Hey, I guess it's whatever happens, happens, as long as they pay their bill.
Yeah, no, I agree, but maybe it doesn't bother me at all. My team members have a problem with it, and maybe maybe because we're more in the South and we're a little bit more yes sir, no sir. Who knows? It could be a little bit of a cultural
Yeah,
thing, but we've
yeah,
definitely noticed that a lot of the times it's just like, oh, Todd, and then I got to hear about it as soon as the patient leaves. Don't let them call you that. Like, I don't care really, but there's only two people I make them call me doctor. That's my
yeah.
parents because they didn't pay for my dental school.
That's funny. When it comes, that's great. Um, I don't really even care about being called a doctor. Like when I'm at church, it's always James. Um, I don't need it for my self esteem. I would use it more from a branding standpoint.
Hmm.
And society does change. I think when I got out of school in the ear- early 80s, things were a little more formal then than they are now. Things aren't as formal as they are anymore.
Well, then
Is one's list, I should say.
how do you respond when somebody makes innuendo, let's say that you didn't go to medical school, or
Oh,
why
I
did you
don't
pick
care.
den?
I don't even care about
Well,
that.
how do you respond to that? Because I blow it off like it's funny. I say, yeah, I'm barely a doctor, but at least I'm not a chiropractor. So I make a joke about it, and
Oh,
all the
okay.
respect to
Are
chiropractors.
these patients doing that?
Yeah, no. Well, so I guess maybe it's different because when I got out of dental school, I started working for a dentist. He
Yeah.
was already 70, and I looked like Doogie Howser coming out of dental school. And so that's the reason why I grew a goatee. It took me like three
Yeah.
months to grow a goatee because I just couldn't. I wasn't very mature. And so it's just always been like, are you old enough to be a doctor? Are you a real doctor? Are dentists real doctors? And I said, well, again, I always joke about it and kind of play it off. Well, at least I'm not
I was a
not the
little
doctor.
s well, I was sensitive like you, Todd, when I was 25 when I got out and started, and I
Sensitive.
remember a few clients when I'd walk in a room, they're saying, "Are you assisting today?" And this is right when I took over a practice. And I would say when I first took over that practice, probably a third of the patients transferred. And one of the comments was, well, you just seem a little young, which at the time it bothered me. So I grew a beard to look older. And I wore that beard for quite a few years. The mustache has always been there since puberty.
Yeah.
That
Well,
doesn't let other people know when you're sweating because you'll never see if you're perspiring on the upper lip, right?
yeah, no doubt. Hey, I got to put my
But
glasses on. I am 51, so I got to read
there you go.
Karen.
Yeah, now we have that look, No, I think I used to maybe to be sensitive about that. I'm not now. I don't really care about that. I do stay a little more focused with branding the practice. A lot of my clients are elderly. I tended to lecture at the AACD last time we could go, and it was on the behavior and thinking styles of the various decade people. You have the elderly clients that are like in their 70s and older. They want the handshake and they're more
Mhm.
formal. You know, baby boomers, we're kind of transitioning out of that a little bit. And then if you get into the younger age group and the Facebook generation,
Mhm.
communication and perceptions change. And there's a different communicational style within each decade of people.
Let
So
me
if you were to contrast someone who's 70 versus 30, maybe you'd see some difference. I think within practice, though, you still market. I'm fairly friendly with my clients, appropriately friendly. Some of my clients that have been there for years, they're like brother or sister or even parents.
actually
And
let me interrupt. Dr. Karen Halpern. I want to throw
yeah,
this
hi
back up
Karen.
here. Yeah, she's watching, and she says, "I'm actually surprised to hear that patients call either of you by your first name too. It happens to me on occasion as well, usually by patients to whom I've not introduced myself to by my first name. I assume it was because I'm a woman." Interesting discussion, and
Yeah.
so Karen, you got to fill us in on a little bit more about that because that would be tough. And James just said I was sensitive, and you know what? That really makes me mad that you'd say something like that. But it really hurt my heart. It hurt my heart that you said I'm sensitive. I am sensitive. I will
You
admit
know
that.
what? I'm very sensitive, and
I wouldn't make
probably
it.
that the hardest part of my practice in my years now is the fact that I'm still sensitive to people, and I've actually used it to allow me to be a better clinician. And one reason why a lot of clients come to me is because I'm sensitive to them. But there's a downside to that as well. And if I don't get my rest, then emotionally it will drag me a little bit. Last week I worked 4 days, which I very rarely work 4 days. And it was a very good week from the numbers standpoint, and the procedures were jammed. And I was exhausted Thursday night.
Mm,
And but it wasn't the physical, it was more of the emotional. And
mhm.
what I find now is that it takes a little longer for me to bounce back emotionally, and it's probably more of a adrenal support. I actually take supplements for adrenal support. And I don't know if you folks out there have looked at your own adrenal support. I'm in my 60s. That's one of the things that kind of goes down. And if you're sensitive and you don't have your adrenal support, then it's going to even be more sensitive to
I
the
can't
various
wait till I'm
avenues of
60.
what we
That's gonna be
do.
so much fun. You'll have to send me some of your pills when I get to 60.
Oh, I see this right here.
What is
This is
that?
my beloved. She makes me my little thing
Your
I
pill
take every
box?
day.
Oh, make sure you take your right ones.
Yeah,
No,
well, I
anyway,
have to make sure
going back to what
I
Karen
can't
was
take the
saying.
morning ones in the evening, or otherwise I don't get any sleep.
No, I bet. Going back to what Karen said, I maybe everybody's sensitive right now. All the holidays and our own frustrations with our own practice, and you and I being males, and we're kind of the alpha male type. Uh, you know, I feel hard for the females that are in our same position because I personally don't know if I'm mature enough to deal with somebody thinking I was the assistant. I think that would be really tough, or the hygienist. I think that would be tough. So it'd be interesting to see how the what are our
Well, let me put it this
ladies
way:
called?
if they call me assistant now, I get paid really well.
Yeah, no. So that
You know,
maybe I tell you what, Karen, if you're still watching, let's be in touch. I'd love to have you on the show and let's talk about this. I think this would be
I
a
think
good
it'd be a
topic.
good conversation.
Considering we know nothing about it.
This is a hard one to swallow. I think maybe it's just I can know academically, intellectually what's right. For instance, no one ever needs to own our emotions. And yet that's the hardest thing that ever happens for me
Yeah.
is not to let circumstances own my emotions. And that will happen when you're tired. And there's a saying that goes, when you're tired, you go to your core fears, which are the emotional memories we have in our brain. So for instance, usually if we're upset by something, or for instance, we get an email from someone and it addresses us in a certain way, and you get that little ping in your stomach of anxiety. That is a emotional tag based in, it's not in the subcortex of our brain. And the sensitivity resides in that area. Having known that for years, I've tried to optimize and create a style of practice that allows me to work through that. Like for instance, my injections are they're an experience for the client and me. I don't rush through them. I use certain techniques. It's real important to me that injections are very comfortable. I wish I wasn't like that, because if I wasn't, I'd still do a comfortable injection.
Mm-hmm.
You know what I'm saying? But yet I
Yep.
don't like hurting people. And so I think part of it's this need of approval too. I don't know if other people out there have this subconscious need of approval. I would like to say intellectually I don't, but emotionally, when I really analyze it, I do. And another thing that really is helpful, and my wife has told me this, is that I take melatonin every night to sleep with, and that actually helps build the serotonin. So you need strong serotonin and dopamines to keep emotionally in a stable zone. And if those get depleted, then it's easier to become very reactive to one's environment. Oh, I could talk about this for a long time, Todd. You got me
Yeah.
going down a corner here.
Yeah. Well, we're losing viewers, James. I think we need to get some dopamine out. I'm just kidding. Just kidding. No, it's important. I've only kicked out a handful of people in my practice, and one of them happened to be this last week. And I don't. Looking back on it, you called me sensitive, and that still pisses me off. But I am. I admit it. And maybe I wasn't on my A game that day emotionally, and she said a few things that were so condescending. And I just met her, and I was like,
Mhm.
you were referred to me. I mean, you came here for a second opinion for a cosmetic thing, and then she just wanted to argue, and I had enough of it and released her right there. And I haven't done that in 10 years, but
Good for
so
you.
who knows? It was probably a little bit of me, but anyway.
Well, I can tell you almost every headache I've had, it's usually not clinical. Or let's suppose you have a clinical headache, and as I tell all my clients, particularly if I'm doing something more than just a single unit or something more challenging, is that we are going to discover potential headaches in the journey of this care, and we
Hmm.
will address it and pivot as we need to take care of it. The biggest problem I've always run into, though, is what's in the patient's mind, and I can tell you, I can identify that really well. The problem is that I still feel like I can help them. Like if you just treat them right, they'll like you, or their
Hmm.
behavior will change, and it doesn't.
Mm-mm.
And the hardest thing I've learned to do through the years is letting people know that they need to get another opinion. That's all. Whenever I say that, my team always knows. You know, I don't want to move through with this, particularly if it's aesthetic. What will happen is, if people don't have a stable platform to the emotions, you can pick it up pretty pretty fast. One thing I look for is if they don't have eye contact, particularly in the initial interview. The other thing is if they're too complimentary too soon, that's big time. You got to really watch that. Or if they cut down other care providers, that's a no-go. It's just a no-go.
I'll just add to that. One of the things that I always have in my head, I think with any of my patients, it doesn't matter if it's a hygiene check or a new patient, whatever. They're, how should I put this? We are comfortable in the operatories. We are comfortable in our building. We are comfortable in the parking lot because we come here every single day. We know the way to get in. We're not rushed, and they're rushing to get to the parking lot, find a parking spot, get into the operatory, so they're doing it for one time, 2 times out of the year. And so when they finally sit down, their heart rate's probably up a little bit. They're, trying to answer messages, and we come in all ha ha ha, laugh, laugh, laugh. Aren't you great? And I always have to tell myself when I walk in that operatory, they're on another plane of stress than what I am. And I think that's really helped me over my years of practicing. What do you think of that?
I think that's brilliant because we have to think about as we think, we can change our emotions if we think about it long enough and reprogram the mind. And there's a whole component to that. But think about this. Let's face it. I would say the majority of my clients have some level of anxiety when they come in. It's just the way it goes, and they may suck it up and you may never see it. But can you actually feel it? I had a client who's a great client, and I always check his blood pressure. And one day he came in and he just looked pale, and I took his blood pressure and it was like 210 over 90. And then I took mine. Do you know what mine was? 210 over 90. And my blood pressure is usually like 110 over 70. So I was actually feeding off of his anxiety. And I don't know if those that are watching right now have ever done this. Take your blood pressure when other people are having anxiety and see if you're paralleling them. And that taught me a lot about me.
Yeah. Well, I suggest you don't parallel all your patients because they're all smoking dope out in the parking lot. You told me they do.
Maybe that's why I've been doing really well lately.
Hey, yes, you're doing great. Let's get to our main topic. We kind of diverted a little bit there, but that's okay.
That was a fun one.
Sorry to
Todd, when I get on with you, I'm always willing to go another road if you want to do that.
But you called me sensitive, and that really hurts. It hurts my heart. All right.
Take some melatonin.
I will. Melatonin it is. Well, you and I have been in the CEREC world for, almost 20 years now and been through a lot of the materials, software developments, camera developments. And I think you and I are both torn that we loved that Omnicam and it worked. And we've done thousands of restorations with it. And then PrimeScan came out and, I think I would speak for you. We would never go back, of course, but there's a lot of people that are on the edge or they can't decide if they want to get into the next layer of technology because the Omnicam is so great. So what do you think about this right now in 2020 and moving into the PrimeScan?
Well, since we're talking about emotions a little bit, maybe I can address it from that standpoint. The reliability of a scan to be efficient, very accurate, and define margins incredibly well, and to be able to rely on your buccal scan cuts down a lot of things that can result from not having that. And though Omnicam was great, and BlueCam was great in its own stage of performance,
right,
there were more things you had to pay attention to in acquiring information. And what I see with PrimeScan, outside of the fact that it offers a plethora of more applications, whether we're doing it virtually in our office or sending it to a virtual lab, the ease and flow of precision is lowering my stress in my day. Because you and I did one of these events for Display Server World, and one of the what did we say about I thought that was, you're the one that came up with it, Todd. What does it do to the bell curve?
Well, so the way I've looked at the history of CEREC and the scanners, let's take the initial camera, the red camera, very difficult to use. You had to powder exactly right. You
Yeah.
couldn't deviate the
Yeah.
camera in the yaw or pitch or anything by any degrees, or the software fell apart. And so it was very user demanding. You had to do
Mhm.
it right, or it just wasn't going to work out. Then you go to the blue camera, which was a little bit more forgiving, less powder, a lot more resolution. It was easier to stitch a quadrant together. Then we get into the
Mhm.
Omnicam, and it was a little bit easier, didn't need the powder, full color, all that. And so the way I described it is a bell curve distribution of use.
Mhm.
Now with the PrimeScan, the bell curve, the majority of people are moved all the way to the right,
Yeah.
way more.
Yeah.
You can hand anybody the PrimeScan and basically put it in their mouth and get a usable model. And we
Mhm.
couldn't do that with the Omnicam. And so the advantage to this is for the doctors out there that are kind of on the edge of getting in the Omnicam or not, is that when you get that PrimeScan into your office, it truly becomes a hub of other things, not just chairside CAD/CAM milling.
Oh, it's huge. In fact, Todd, I'm going to go to a
Yeah.
clinical slide here. And this is what I think of when I'm thinking of PrimeScan now. In other words, there's nothing I can't scan with it. Even if I were to do a denture scan on edentulous tissue, I can still create a supportive printed base plate and then do my border molding and then scan that back into the computer. And that's very similar to what I did with this case recently of where here's a upper denture that we made in our office about 20 years ago. So what we did is we just did a 360 scan of that. Or here, this just documents what you can do on how effective the PrimeScan is, just scanning edentulous arch. And from this, we can make base plates, and that's what I did with this case. What it does is it cuts down on the amount of appointments we have, and it's really nice to have that information stored digitally, so you don't have to have models. So even if I'm doing a base plate and I'm going to border mold that, I'll then take and scan that impression into the computer. And this is that denture duplication right here, of where we can scan 360 of the denture prosthesis in, which has our occlusal plane we want, even though we're losing our curve of Wilson a little bit, and that's the internal surface. And
Mm-hmm.
from that, we're going to go ahead and print. We're going to go ahead and print this, and then we went ahead and border molded that and sent that off to the lab with the bite and everything there. So even though that's one of the few analog techniques I still do, I find with PrimeScan, I don't do analog for almost anything now.
No, me neither. You know what I liked about that denture you scanned in, and I think a lot of maybe even CEREC owners wouldn't recognize this, is the Z value of it. I mean, that
Mm-hmm.
denture, I mean, it had to have been this big. And not only the Z
We,
value, but it was able to do two Z values, which, the palette side
mm-hmm,
and then the other side of the intaglio
mm-hmm,
side of it too,
mm-hmm.
which, in
And
earlier
the,
versions of
the only
CEREC,
thing I had to do on that, I'm sorry, we're on about a 2 second delay here, so I don't mean to interrupt you.
that's okay.
Um, the one thing I had to do to catch the palette of the denture would I placed just a little bit of impression material on it to make it a little rough, and it would scan effectively that way. And then what I do is I take that in a mesh mixer, just make sure there's no little micro voids in the impression, and then we print it. And it was amazing. What was amazing with that, Todd, was when I placed the duplicate in the mouth, it had better retention than his denture had. Because what I did is I reamed out the undercuts in the denture to take a wash, right? And he
Yeah.
goes, "Will the final one have that much retention?" Because you love it when you can try to yank the prosthesis out and you have that displacement.
Hey,
I know 20 years ago I spent quite a bit of time creating that border molding, and that's one of the things I learned in dental school. In fact, I don't. A lot of people don't know this. I almost went back and got a pros residency And in fact, I was planning to do that, and then some other things happened in my life which took me away from that, just because I was really good at making dentures back then.
Hey, I got a
Can you imagine?
question.
That would have been boring now for me now. I don't mind
I
doing
don't
one now and then, but not all the time.
I don't do any dentures. Got a question for you. Which catalog do you put the denture into when you scan that? Which catalog did you put that in?
Well, it depends. If you're exporting it as an STL in the administration screen, you don't have to put anything down. And once you scan it, you just go up and export as a STL and move it out that way. So I'm going to put it in the upper catalog. And
Yeah,
that's what I did. In fact, most of my study models, if I'm exporting as an STL, which I export most of my study models out, if I need to print them for like any purpose, whatever it is, I don't bother on placing a restoration. Now, there's another way you can trick around it. If you need to export it as a DXD, you got to have some type of restoration marked on it. So
right.
we'll do like a wisdom tooth and let it process in to the manufacturer screen and then export it, and then that gets lost. But that's only when I'm using it for in-lab for certain purposes when I export it as a DXD. But
Uh,
most of my exports are STLs.
yeah, we usually do it that way because I want to see it. I want to see the models articulated with the bite pattern on it. And even though there's a margin out on the tissue and some wacky proposal, at least it gives us more information. And you can use the
Yeah, that's
articulation
true.
mode as well.
Oh, here's well, I was going to get into something else because I just finished a set of veneers on lower 22 to 27, and these are really petite teeth, which means I wanted to mill them EF burr.
Right,
And I can only mill EF on laterals and centrals if I go to 5.01.
right,
So I'm using the latest version. So with that, what I'll do is I'll design everything in the latest version, and then I export it as a DXD and then import it just to mill in the prior version. I noticed that happen when it was set up for Prime Mill, and I don't know what it is. And I discovered that when I was upgrading my wife's veneers, of where I'm a big fan of the extra fine because I'm fairly conservative, and
yeah,
I can mill them really thin, no chipping whatsoever on the margins. And so if I'm doing a really conservative set of veneers, I'm definitely going to mill EF, which usually doesn't make it one appointment if I'm
right.
doing multiple units. But there's times you have to work through it, but it has nothing to do with the PrimeScan. It has to deal with just software compatibility. But the other thing I would like to say, Todd, on this is I wasn't part of the beta process for PrimeScan, but I was for BlueCam and OmniCam. And I do have to say I was one of the earlier people to get it. I think I got it at the end of February when it first rolled out. And I would have to say the PrimeScan is probably the smoothest rollout I've seen. I know in the earlier version of the software we had a few crashing issues. I don't really see crashing hardly at all now, and a lot of it was overscanning. And but I think the flow for basic dentistry and PrimeScan is just seamless. It's like you can drive it and put it almost in autopilot as long as you get enough occlusal reduction.
Yeah.
But
I think that
I cannot imagine someone not having PrimeScan right now. Seriously.
no, it really is truly the hub of a digital practice now.
Yeah.
You know, the Omnicam was close. It still had limitations, and we couldn't quite get through all of it. But now, you know, doing ortho, sending it to your lab,
Hmm.
you know, if you're implant planning, printing, and you get all of these things, and they're not 100% seamless. But the thing is that it's more complete than any other digital platform there
Hmm.
is, and it's the fastest one there is, and it's also predictable. You know, the other thing, I've got one right behind me.
Yeah.
So there we go. You know, one of the big complaints of the PrimeScan is it's so heavy. Oh my gosh, look how heavy this thing is. And you know, it is bigger than the OmniCam, but you know, with the OmniCam, you've got here. I've got an Omni somewhere. I got to reach too far. You know,
Yeah.
the
Don't
Omni.
don't let the tower fall over.
I know I dropped it last time. I nearly died
Yeah.
when I saw my AC unit fall over.
Oh
Anyway,
man.
so with the Omnicam, you've got to get 90 degrees, to get that
Mhm.
data. So, as you're holding that Omnicam, not the PrimeScan, but the Omnicam in the mouth, and it's gathering data, you're building data just to get one little thing filled in because you're trying to get shine, fluid or something to fill in the data. And so you're building the file a lot. And a lot of Saragonders do not realize that most of their problems in the software come from too much scanning, too much
Over
data.
scanning. Absolutely.
But with this, it's probably about 60 degrees, as you're coming
Mhm.
into it. So to come around a corner, you don't have to get it all the way around past that second molar like you did with an Omnicam. So yes, it's bigger, but it can almost see around corners. It's crazy.
Yeah.
What do you say
Well,
about that?
with the blue cam, remember, the camera was at the end where it wedges,
Yeah.
and the prime scan is similar to that because first of all, you don't have to pitch and roll it as much to gather data. And then the other thing that I love about the prime scan is the back side of that camera, Todd, I use as a tongue detractor or
Yeah.
a lip and cheek retractor. And as a result, I have a tendency when I do that to start over the premolars. I used to always start distal and come forward, but I'll start
Hmm.
over the premolars, and then on the upper, I'll just push it back and roll it to the buccal, and that way you get your buccal corridors just like that. And then if I'm doing a full arch, I'll just bring it right around the occlusal table to the buccal on the over, and then finish in the rest of the data. Um, we do a lot of full scans for appliances, and it's amazing on where I'll set the bite where I want the vertical to be for the appliance and just use the bilateral buccal scan to put that in there. And these appliances are coming back and they're just, the
Yeah.
occlusion's right there. It's,
That's the other thing that we really need to focus on is the trans arch accuracy. So,
mhm.
Invisalign has their D88 or whatever value it is,
Yeah,
it's the
yeah,
nonsense thing. But it's important though because if you don't have the accuracy from the cusp tip of the upper second molar to the distal buccal of the contralateral second molar, that keeps you from seating an appliance, and
yeah.
that's
And
no
then
bueno. That's not
it's
good.
gonna bind. And the other thing that I found with this, Todd, is that I'll use it as a bilateral buccal scan, even if I'm opening a vertical for a restorative procedure. Now, usually when
Yeah.
I do that, I'm going to do milled out transitional restorations first, let their bite settle in, and then I'll restore them in sections so I never lose their occlusion. The bilateral buccal scan with the prime scan for that is spot on. It's just amazing to me on how accurate it is.
Yeah, let me make a couple other points that Dentsply Sirona has done a really good job. Not only do they make the technology better, faster, more accurate, more predictable, but they made it more hygienic. They made it
Yeah.
easier to use just on a daily basis. So, we have three different tips for this now. The traditional tip, and then the one that has a little disposable piece that you can sterilize this,
Mhm.
and then, we'll see if I can do this without breaking it. The camera's on the inside of this now in the housing, so you're not getting this contaminated. And,
Mhm.
in virus world now that we live in, it's getting more and more important that we're living in more of the sterilized world. And, with the Omnicam and previous cameras, we just kind of did what we did, right?
It is. Hey, I have just three keynote slides I like to share because this is an area that's probably the best for me with Prime.
Okay,
And I
you're
said,
up.
is it time for prime time? And that's margins. We all live by the margins. And this represents some cases I've done with CAD CAM over a period of time. And I use it in lectures where I'm presenting to a neutral crowd. They're not digital people. Maybe they're checking out digital dentistry. And I always ask them this question. If this client were a new client in your practice and this was an x-ray, how would you assess the quality of the margins and emergence on the restorations on this restorative dentistry? And the room just goes quiet when I share the fact this is all done with chairside CAD CAM.
Hmm.
Now, what I really like about where we are now, and this is on 30, that's a katana, that's a try-in. So in other words, I took x-rays because I was having to go a little deep there. But this is the image. And I have found that with PrimeScan, I'm doing more burr curettage. So I use a curettage burr, and look at the distal there. We had to remove quite a bit of tissue. And then when you're drawing margins, as you rotate the model, you can see precisely where that margin is. So watch the rotation here. You can actually see that margin is highlighted, even though we're subgingival. See that little bead line that you can see there? And I would just go around and trace it. And I do a lot of my impressions this way now if I'm digging deeper. I just did a case like this on one of my dental team members, and we had to go down subgingival quite a ways. And I'd like to always verify that with an x-ray before I see, but that's what we're seeing now with them. And obviously if I had to powder, I couldn't do that. And I did a little bit of that with OmniCam, but I never trusted it. And so I'd pull out the laser and do a lot of troughing, where I'd be troughing into the biological width. Obviously, we're not on the biological width in this case, but I do a lot of burr curettage now, and that's the type of margin clarity I'm getting.
Let me show you a bit of history also. So I want to demonstrate a little bit on.
Yeah.
So this case I did with the red camera years ago, a little inlay that I probably should have done a composite on, but I probably had to do a CEREC that day. And I'm very embarrassed about this little inlay because back then I learned from a trainer that you could use resin to make the stains, and I was like, that doesn't even sound right, and it doesn't last. But we're going to focus on the second molar, the PFM, because it later broke. And one of the other things about the PrimeScan that is so good is that we can use it as a diagnostic piece of equipment. So for everybody out there, don't forget to use this as an intraoral camera. So we got the PFM off, showed the yuck underneath it. Not only was the ceramic broken, but he had a huge chicken grabber, as we call it in Texas, open contact. And if CEREC can see it, CEREC can mill to it. So we did have to laser off a little bit on the distal lingual, but that mainly it's because if the tissue falls over the margin, it can't see it.
You can't see it.
Yeah, or you could do the burr curettage that you were saying, but look at my little inlay. You can see the little margination on the distal buccal. That's not too bad. That's pretty good for almost 18 years. Pretty good.
That looks really good, in fact.
So we played.
What was that material? Do you remember? Do you remember what it was?
I do. It was ProCAD.
Yep.
Yeah, the precursor.
That works like enamel.
Yeah, no, it worked out really good. It's a great material as long as you bind them in right.
And that also shows that you had a nice, clean, tight margin because there's a self-limiting wear there at the margin to junction, which is half the gap.
Yeah, great study.
Yeah,
a lot of people, they freak out about margination on partial coverage restorations, and they shouldn't be, because I've always, here, let me get back to us. What I've always said on the margination of partial coverage is that you should never do direct composite ever, because if you think of a direct composite as one big margin, you don't have anything to compare it to, so you don't even see the margination because the entire thing is wearing out. But when you have ceramic up against two structure, you see the little margination. Oh my gosh, it's so bad. No, it's not bad. Save the two structure. Don't you agree?
Oh yeah. In fact, I started doing conservative restorations going back into the 80s because I started all my work with, I was very minimalistic because you had to be. If you're using macrofelspathic refractory cast restorations, they would fall apart on you. And so you had to bond them to enamel, and a lot of them are still there. They worked extremely well, and we would preserve as much enamel as you could. And that's what we did even through the Empress world and the Vita world. And
I'm going to finish this up, James, real quick. Sorry.
Yeah, go for it.
Whether it's biocopy or biogeneric, which is still pretty much straightforward in our programs, the fact that you have better data not only on the prep side, but you also have it on the occlusal side, but you also have
Hmm.
possibly better articulation of the two models because the
Oh,
data is
sure.
better. You can dial your maximum intercuspation in so much better. And you know what I know our topic isn't the prime mill, but the prime mill, it just rock and rolls with zirconia, but still with Emax, you can mill crowns in 5 or 6 minutes with it. So we're seeing some really high end,
Hmm.
fast
Hmm.
milled restorations with the prime mill. And then we'll fire that in, and you were mentioning the X-rays.
Yeah.
They're almost indiscernible. I mean, I love talking about full ceramic dentistry to my patients because they get it when they're when you show them an X-ray and they are totally blocked out with an amalgam or a PFM. They
Hmm.
understand that we can't see underneath it, and then when you show them something like this, they definitely get a better idea of what the capabilities are when it comes to ceramic digital dentistry.
What was your cement there?
So I use two, I still, well, I use VeriLink Aesthetic on that one, but I still believe in multi-link. There's a reason why I use multi-link still. And uh, I think you'd agree with this. You still like to etch. I like to see the blue
Yeah.
edge on it. I think it's
Yeah.
important. But the one thing that is not so bueno when it comes to the phosphoric acid is if you have it on freshly cut or freshly touched tissue, you put it on
It's going to
there,
bleed.
it's going to bleed. And so
Yeah.
whenever I feel like I'm in that very deep zone of something that's going to potentially bleed, we'll switch it over to the multi-link and I'll still etch, but I won't bring the etch all the way to those zones where I think it's going to cause any sort of bleeding or a problem because the organic etch and the A and B component of multi-link is almost as good. So I'm getting it almost
Yeah.
everywhere on the tooth except for that one area.
Yeah.
So I still use multi-link in those
Good.
situations.
Well, we have so many, and Panavia acts the same. Their adhesive system
Yep.
acts the same way. And it's great to have all these great products now.
Yeah, it's
Yeah.
fun to be in dentistry right now because the PrimeScan, but also our materials. It's all like, and our computer speeds, our softwares. We are really changing the way we have to prepare teeth or restore teeth
Yeah.
because of our technologies. I guarantee you're not prepping teeth the same way you did. When did you graduate?
In the early 80s.
Just giving you hell. Just giving you a little, just bantering just a little bit. No,
That's
but
good. I would say, I recently saw a video on YouTube of where they were using the Tucker Gold technique for some gold inlay, it was a really nice video. And this is a guy up in Washington. And I follow him
yeah,
on YouTube, and I was just watching on how you cement in your gold, and then you take your instruments, your rotary instruments, and you burnish that gold onto the margin, and you thin it down so you can't detect it. And I'll tell you, those margin seams hold up for a long time. And the early part of my practice was really into gold conservative restorations like that. And when I look at ceramics, I think the same way. We want to seal those margins as best we can with the material we're using because it holds up better. And then a lot of times now, if I'm on the occlusal surface, I'm really looking at that seam. I just did a onlay on one of my team members, and I preserved the buccal cusp. So I was really looking closely with my 6 loops to make sure my seam on that margin was just nice and tight, because I know, just like the restoration I saw there, is that when I see minimal indication of a seam 18 years later, I know the margin was really closed well. And
hey,
and
I got a thought for
yeah,
you.
yeah,
Imagine if you're still doing a lot of gold, which I did plenty of gold. I was trained to do gold inlays. I know the preparation styles very well. Imagine if you could do gold through CEREC with the PrimeScan, the way our models are so good. You and I both have a Sega printers, and
Those are awesome.
imagine if it just milled out the wax up. Yeah, no, that's a great model right there. And so imagine you still have to invest and cast the gold and
Mhm.
everything. But what if you were doing semi-digital work? What would you do gold again? Maybe we should start throwing some gold in again.
Um, I don't have a problem with gold. I do think um, it's a really good discussion. Gold has a good track record. I know one of the lab technicians who teaches has taught me, and he helped me through with some of my accreditation cases through the AZD. But they pretty much design everything digitally, and then they will invest it
Hmm.
because they're saying the digital mill is that accurate.
Yeah.
So whether you're doing ceramics or gold, I don't think there's an issue there. And we do know, I did a lecture to CDA last time they had one that was open, and I think you did one virtually this year. And in my research for that lecture, I found several articles that show the fact that a scan model printed on a good printer is more accurate than a PVS in stone within the accuracy. And I would say I can see that with the fits of restorations. When I'm doing large cases, I'll print a model and then I'll put it into the model. The only difference of a model is that when it's stone, it's really hard and rigid,
Hmm.
whereas a model can be a little bit pliable, a little bit. But
Yeah, you got to have
for
it cured
instance,
right.
yeah, I'm putting a veneer case in tomorrow that I didn't do in one appointment because they're the really small veneers and petite, I call them, and I print the model on the Sega and finish it on the model, and they just drop right in. I can fully trust the interproximal contacts and the finishing qualities of this. So it's a little different than stone, but I actually think it's more accurate than stone, and I can
Well,
see that. And I just did a 8-unit veneer case with, I would say I broke the interproximal prep on most of them, and I finished them on my printed model, and they just dropped in. The interproximal contacts were spot on.
I
But
think we're going to lose our licenses, our dental licenses, if we say printed models are more accurate than PVS and stone. So let me reword it so we don't have the government
well,
coming
I,
after
I can show you. I can show you literature that documents
us. I know, but let me reword it. Uh, it's more predictable. Like think of all the variables that happen with a PVS and mailing it and then pouring it up if your powder water ratios aren't
oh
exactly
yeah.
right. Did you vibrate it just right? So there's a lot more variables. So digitally, we get the same result almost every single time. And let me wrap up when it comes to the PrimeScan about one last little thing, because we've covered some really cool things. We've covered the high technology, the hygiene of it, the options for diagnostic reasons, orthodontics, implants. But really, when it comes down to it, I think is the workflow in the office. How well does it flow in the, as you call the clinical theater? It's not all about us. It's not all about the dentists that are working. And so when we can
Good
hand
point.
some, yeah, when we can, again, when I said the bell curve moves to the right, if we can delegate it so much easier without a lot of training or we have predictability, which is the most important thing. If that human, other than me, can scan something in and we get the same result, isn't that what we want? And
That's what we're after.
yeah, and I don't think you can always get that with the Omnicam. So
That's a really good point. Is that basically
yes,
you said it moves the bell curve to the right? Well, that's for everyone who's using it, regardless of what their degrees are.
right?
And I think the power of what we do now is delegation. I know you have an incredible team for delegation, and with Cindy, she's an incredible educator as well. So you're right there at the top.
Let me show you. I'm going to show one quick
Yeah,
video because I want to show everybody how fast uh,
yeah. Let's
the
do
buckle
that.
bite can actually happen. So let me go here. So I really think that the PrimeScan is a lot more of the hub now, because it's not just chairside milling, but it's, like James and I were talking about, the printing world, and our good friend August is the guru and all that. But the ortho and the implants, the possibilities of all that, including our dental labs, is, you got to upgrade, because you're going to live these worlds a whole lot more than what you're doing with the OmniCam. Now, this is my assistant, Cindy, and my other assistant, Ty, and we're doing a full arch scan right here. And I still believe it's a two-person process, because there's too many things to see. So like Cindy was seeing something as she was scanning, and Ty pointed something out. So we have verbal dialogue as we're scanning, so we know what we're trying to do. And the reason why we do this, we teach this in our CEREC ACEs class, is over scanning is a big problem. You get addicted to using the scan, and you think you're making it better and better and better, when in reality you're not. Fill in the hole and move on. And so when you have two people doing the process, it's a lot more efficient. But James, I wanted to show this, because this is a little video of the buccal bite that happens. Now watch how fast this happens. So we're going to tell the patient to bite down, bite hard. We're going to pull your lips back, because we want them to bite into their, let's say, compressed maximum intercuspation. Cindy puts the camera in, and boom, it's already done. You can see the two ghost images right there. And
that's auto mounting. Remember when we had to wait for that to happen in the model screen, and right now, whether you have it together, and we talked about a compressed PDL, and that's one thing I really like about even with the OmniCam, but the Prime's even better, and that is if you all find your CO right now, those PDLs are moving 30 to 90 microns, right? And so if we don't have them engaged,
how many
30
microns?
to 90 microns, based on who it is.
90?
Yeah, so let's take this small one on that. And I got that one from listening to a lecture on Steve Chu at the ACD a number of years ago. But let's say it's 30, right? 30 times 30, that's 60. That's enough to adjust, right?
Yeah,
so if you think about it, if you find your CO right now and just kind of find it and then slowly start bearing down, you can actually feel compression of your PDLs. And that's exactly what we do when we take articulating paper. I can't tell you how many times where everything looks great, and then you say, let's bite it another few times, and then all of a sudden you pick up a slide or a contact that you didn't initially see. So, there's a lot of complications to that. If they have a hypermobile joint, maybe they're not fully seated yet. And yet a lot of times it's just the PDLs and the maximum intercuspation getting connected again, and that's how I want a patient to leave with the final restoration. But what's nice is that we can actually take that. I'll just show. Give me full screen again.
Yep.
And I'll go back to that. So basically, what I'm doing here is I seat the patient up a little bit. So if they have a hypermobile joint, their joint doesn't drop back, and then I have them bite quickly about 12 times, so they can get that coordination muscle memory down. Okay, and then when I'm doing this, if it's one restoration, we can take this before. We're going to go from the mesial of the distal tooth to the canine, and that will be very sufficient to mount that model and really feel secure with what you're doing. And that has made all the difference. Like, let's say we're doing a buccal scan for an implant, right? Restoration. So you want maximum intercuspation and compression of both arch PDLs, so that implant's never the first tooth into occlusion, right?
Mm-hmm.
And that's the same thing I do when I'm doing restorative dentistry, because that's how we adjust them in when they leave. And there's other concepts on how you build occlusion up and staying off of inclined slopes and stay away from working interferences and balancing. But I think that I started doing it. I think that was 2010 that I attended that lecture, and I came back and I think I started that on the Blue Cam, and it started making a difference. And people always are asking me, well, what parameters are you using? I'm having to adjust my occlusion, and I can't overemphasize. Sure, you want good parameters, but you've got to take a buccal scan that's consistent. And since I've been doing that I call it a compressed PDL bite. I tell you, that's probably the best thing I like about this system.
Mm-hmm.
I get angry, Todd. It goes to my amygdala
It's because
when
you're
I have to adjust
sensitive.
the occlusion. I'm sensitive. I'm really sensitive about high occlusion.
Let me give you
Yeah, and
one. Let me give you one more thought about the the maximum intercuspation position. You know, whether you're, as you said, 30 to 90 degrees, whatever it may be. When you bite into your maximum intercuspation, you're pressing into it. That is a very stable position. Your brain knows it extremely well and hold it. So
muscle memory.
yeah, so imagine, physical impression, whether you're doing a triple tray or bite registration material, and you're having to swim through all of that. I've always made fun of triple trays because if you're doing the right side, one of three things happens when you're in that impression. One, they bite down and they go right to it. The perfect. That's
They
one.
grab it. Yeah.
Number two would be they're trying to help you. They're reaching over there thinking that that's what they should be doing. Or three, we say this in Texas, they're numb all the way to Dallas. They're numb all the way over here, and they can't feel.
Well, no, they're numb all the way to El Paso.
El Paso, yes.
Where I live.
That's right. You're in.
I'm
you're
sorry.
in
Go
West El
for it.
Paso. But they're afraid, because they can't feel anything. They're afraid they're going to bite something. They're pushing into maybe part of the tray. They think it's their tongue, and they're not. And you're going, no, 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 trying to get them up into position. I mean, they think that world is more predictable than our world. That blows me away.
I've been there. No, I really enjoy digital dentistry on being able to manage occlusion, and also, there's a lot of different occlusal styles, and I think all can be addressed. And I always encourage people to use with what they're trained and what works for them. And having said that, I really like the ability to manage where the cuss tips and the fossa and the marginal ridge are going to interact, because most of us, and as we get older, we get occlusal wear. What happens? Our lower jaw walks back. So in other words, and we can document that on CBCTs, as we get wear and tear in our occlusion, the lower jaw will slowly start sliding back. So when I'm making a restoration, I want to make sure I'm staying away from a class 1 interference. And what that means is that when they're biting down, I don't want them to pick up a balancing or working interference that would want their jaw back, because that's what balancing and working interferences will do. Actually will want to retrocline the jaw position when we bite down. And even if we're doing one restoration, I would say most of the bites I work on are not ideal. Mine's not. Todd, you should see my condyles. You could go fishing with them. They're remodeled and beaked forward like this.
Oh yeah.
From premolar extractions. So we want to do the best we can with what we have. And let me just leave it this way: PrimeScan is incredibly great for managing good buccal scans. I mean,
yes,
I would get it just for that. But I mentioned earlier is like PrimeScan lowers my clinical stress because, and that's what we started out with, Todd. First of all, you really can identify and clarify margins with it. It's really, really nice for that. Number two, you can rely. You said this. It's reliable. And what's the reliable part of it is making sure that we're mounting the models correctly, which is a clinical technique, but that once you scan it, it's going to be there for you. And then you can trust and work through the parameters as you need to, so you can calibrate it relative to how you finish your restorations. And once you have that system down, it's really pretty seamless right now, particularly if you're just talking about single restorations or quadrant restorations.
Well, think about all.
And we have incredible materials. I mean, you've got it. You've got the materials that have brought us here, and you've got zirconia now. You've got great aesthetic options. You got Katana. It's a fast turnaround. You got the Prime Mill, which will really buzz through the Katana very accurately, which I would say half my posterior molars now are Katana with the Prime Mill. Because I can get in, get out. I have a lot of elderly clients that have root decay. I want to cement those in with a resin glass ionomer. I mean, there's so much that we have now that
Well,
makes
think
our
about
life better. And I would say Prime Mill, low stress.
Yes. Think about it this way. Think about adapting this digital dentistry years ago. They always talk about the learning curve, the learning curve, the learning curve, the learning curve.
Mhm.
And, it was always the camera and the powdering. Now that's really not part of the learning curve. I mean, it is a little bit, but now the learning curve is all of the plethora of materials that we've got and the indications that
And
we've got and the bite
yeah,
guards and the implants and everything. And so, if you've got the right technology, the right scanner to capture the data reliably, easily, predictably, you can have fun with all these different avenues of dentistry. And so,
mhm.
I know we're biased. You and I are very biased because we've always been in the
Sure.
CERC world, but it's because it's the best. And I'm not going to
Well,
apologize
I,
for
I
that.
have to tell you this. I was, when Patterson started using other scanners, I had all the other scanners in here. I didn't purchase them, but as a trainer and educator for them, I learned how to use them all quite well. And until PrimeScan came out, I would have to say 3Shape was definitely the sweetest one for me.
Sure.
Um, but now if I were to put 3Shape is excellent, but when I put PrimeScan next to it, I still will gravitate toward Prime because I know the system and it works well chair side for me. We're at a good time. We're at a prime time for PrimeScan.
Yes, sir. And we are at a good time to close things off. Thank you, everybody, for joining us tonight. It's always an honor that we have
Yeah,
such people that follow us. And James and I, we do talk a lot before the show and after the show. And one of the things we always hit on are the people that support us, not only with our teaching programs, but also with our dental show live. And we love you guys. It's a small
yeah,
world
we
and
do.
it's a competitive world,
Thank
but
you.
yeah, thanks so much. So, oh, James, I got two things to say, and then we're going to finish.
Yeah.
We will be interviewing the fastest dentist in the world.
Yes.
The fastest dentist. Nobody's faster than this guy, and I'm going to leave it at that. And then the second thing I want to say is that you may not be using Katana very long. There's something coming around the market. I'm gonna leave it on that. All right, everybody, thank you so much. Sorry, buddy, had to end it that way. Bye.
Be safe.